Good morning, good afternoon, and good evening, all. And thank you for joining us today for this ICAP World AIDS Day event. I'm Wafa El Sadr, and I'm the ICAP Global Director, and I'm honored today to moderate today's event commemorating World AIDS Day. Now, for a little bit of history, World AIDS Day was launched in 1988, which is 35 years ago, as a day to bring awareness to the HIV epidemic and to mobilize the global community in addressing this massive epidemic. Now, each year, a theme has been put forth for World AIDS Day in a way to focus all the global efforts on an issue of high relevance and priority. This year's theme is Let Communities Lead, in recognition of the importance of community engagement and, importantly, community leadership in shaping the HIV response. Other themes over the years have focused on issues such as ending inequalities, closing the gap, zero discrimination, among many, many, many other important themes. And all of these themes, in a way, have captured a moment in time in the 4 decades of this epidemic. We are honored today to have with us 4 global leaders in the HIV response, each having contributed in their own way to advancing the efforts to ending AIDS as a public health threat. Now, let me describe to you today's program and briefly introduce our guest. Today, we will start with introductions, which I will continue to provide, to be followed by a keynote address that will be provided by Dr. Jessica Justman. This will be followed by a panel discussion where we'll be joined by 3 global health leaders, and then we'll end with taking your questions to the panel to inform our conversation. Just to remind you that anytime during this meeting, please do submit your questions to the panelists using the Q&A box. And this webinar, as all other ICAP webinars, are recorded and posted with the slides on the ICAP website. So let's move on, and I'll introduce Jessica Justman, who is going to provide us with the keynote address today, which is, as you know, similar to our webinars, entitled, Is the End of AIDS in Sight? So Jessica is an infectious disease specialist and epidemiologist, and she's had over 2 decades of experience in advancing HIV prevention, care, treatment, and more recently has pioneered a precision public health approach to understanding the global HIV epidemic. Her research over the years has focused on both international and domestic HIV epidemiology and HIV prevention. And also as ICAP's Senior Technical Director, she has overseen the development and strengthening of ICAP's clinical laboratory programs, as well as its strategic information and population-based surveys across a range of global projects. She is also Associate Professor of Medicine in Epidemiology at Columbia University. I'm going to hand it over to Jessica to provide her keynote address, and then I will introduce our panelist speakers at the end of her presentation. Welcome, Jessica.
Great, thank you very much. Let me just take a moment to set up my slides, and we'll make sure that everything is working. Hold on a minute. Two.
Yeah, it looks good.
Okay.
Okay.
Looks good?
Yes.
Okay, wonderful. So let me also say good morning, good afternoon, and good evening to everyone. And thank you so much for joining us. And as Wafa described, I'm going to provide us with some reflections on the HIV epidemic and where we've come from, and some thoughts on where we're going. I'll start with some global snapshots I will then summarize accomplishments of the HIV response, describe major gaps in epidemic control, talk about some threats that we have to grapple with, and reflect on the way to move forward. So just to begin here, we've got these numbers that show us the progress over the past 20 years. And so you can see that globally, the number of people living with HIV right now is 39 million and is quite similar to the 40 million that were estimated to be living with HIV 20 years ago. So that's about the same. The number accessing antiretroviral therapy, however, has moved from 400,000 to nearly 30 million, which is 75 times higher, an amazing accomplishment. Of course, 30 million is not the same as 39 million, so we can already begin to think about what that gap means. The number newly infected in 2003 was 5 million per year and is now nearly 4 times lower at 1.3 million. And the number of AIDS-related deaths in 2003 was 3 million and is now nearly 5 times lower, or 1/5. So how was all of this accomplished? Well, an important part of the story of the accomplishments of the global HIV response consists of the 3 red squares here on this slide. In 2014, 9 years ago, UNAIDS defined the care continuum targets for 2020, and these squares represent the 3 targets, which we refer to as 90-90-90. And for those of you who are less familiar with these targets, this means that by the year 2020, it was necessary for at a global level for 90% of people living with HIV to be diagnosed and aware of their infection, for 90% of those individuals who were diagnosed to be on treatment, and for 90% of those on treatment to achieve viral suppression. And this model laid out the path to HIV elimination by 2030. The 2014 plan to eliminate HIV by 2030 depended not only on achieving the 90-90-90 targets by 2020, but by achieving the targets at the level of 95-95-95 by the year 2025. And this plan also included a reduction in the number of new infections to a target of 500,000 or fewer, and a target of 500,000 or fewer by 2020, and 200,000 or fewer by 2030. The UNAIDS plan also includes dramatic reductions in punitive laws and in the experience of stigma, gender inequality, and violence, with the goal of zero discrimination by 2020 as well as by 2030. So we can now look at the global accomplishments in terms of the global status of the HIV epidemic as of 2022, according to the UNAIDS targets, which we just looked at. So these are measures of prevalence in contrast to the absolute numbers that I showed you just a couple of slides ago. So globally, 86% of adults living with HIV knew their HIV status in 2022. 89% of adults who were aware of their HIV status were on antiretroviral therapy, and 93% of those who were on antiretroviral therapy had achieved viral load suppression. We can also look at this as the product of these 3 measures of the care continuum to understand what the viral load suppression is among the global population of all people living with HIV. And we do this by multiplying those 3 numbers, so 0.86 by 0.89 by 0.93, and that helps us see that as of 2022, 71% of all people living with HIV globally had achieved viral suppression, which is certainly a very important achievement. But again, it gives us a picture of what the gap is and where we need to go. I want to mention that as of 2022, 3 countries, Botswana, Eswatini, and Zimbabwe, had achieved their 95, 95, 95 targets. So that meant they did it early, before the year 2025. And another 16 countries, half of which are in sub-Saharan Africa, are close to achieving their targets. This diagram illustrates PEPFAR's impact by the numbers. And I won't walk you through all of the numbers on the diagram, but let's just look at the one on the upper left, where we see, and we have heard about this, that 25 million lives have been saved through PEPFAR's impact. Another important contributor to these accomplishments is the Global Fund. And they have supported, for example, over 24 million people on antiretroviral therapy for HIV in the year 2022. And the rest of the chart shows other achievements supported by Global Fund in the year 2022. And ICAP has been very proud to contribute to some of these achievements and impact over the past 20 years. And what we can see here is that with ICAP support and the generous support of PEPFAR and Global Fund and others, 51 million people have been tested for HIV, 9.2 million people living with HIV have been screened for TB, 2.5 million people cumulatively have been provided with HIV treatment. Over 200,000 people have been given access to pre-exposure prophylaxis or PrEP. Over 400,000 healthcare workers have been trained at close to 8,000 healthcare facilities, and close to a little over 7,000 laboratories have been supported with technical assistance. And not surprisingly, with all of these accomplishments in mind, there has been a dramatic decline in the number of new infections over the past 10 years. There's been specifically a 43% decline since 2012, when the number of new infections was 2.3 million, to 2022, when the number of new infections was 1.3. And how has all of this been achieved? Through partnerships with ministries and communities, certainly picking up the theme of this year's World AIDS Day, through commitment at all levels of the healthcare system, through task shifting, evidence-based programs, comparing performance to targets. And we've just been talking about the targets and their importance, through surveillance systems, data systems, better medications, strengthening of capacity and systems, again, at all levels of the health system, and through innovations. So there has not been any single magic bullet. It has really taken this multiple approaches to achieve all of these all this progress. And yet, why are new HIV infections declining so slowly? Yes, we've had a lot of progress, but our 2025 target, just in really 2 years from now, is to have only 370,000 new infections per year. And officially, from the end of 2022, we were at 1.3 million. So that's not even close. So we need to keep pushing. How can we do better? Well, in order to continue to make progress, we have to understand where the gaps are, and that requires continued measures of how we are doing. All of these different measures, which I'm showing here as this sort of diagram of a jigsaw puzzle, it helps us to know our epidemic. It helps us to guide our resources and our programs to the geographic and the demographic groups most in need. We'll look at some population survey data to start with. Since 2014, the population-based HIV impact assessment, or PHIA project, has conducted nationally representative surveys to capture the state of the HIV epidemic in the most affected countries. PHIA surveys are being conducted in 15 PEPFAR-supported countries. With very few exceptions, they all share the same primary objectives of estimating national HIV incidence and national prevalence of viral load suppression, defined as an HIV RNA level of less than 1,000 copies per ml. Each country lays out its own secondary objectives, which are typically very numerous, but they all include subnational estimates of adult and pediatric HIV prevalence, HIV drug resistance, prevalence of detectable ARVs, CD4 distribution, and others. The map on the right shows you by country which countries have had, for example, 3 or more surveys in that very, very dark green. That's Eswatini. Several countries in yellow have completed 2 surveys. Some countries in the blue have completed 1 survey. And then we have a first survey in the planning stages underway in purple in the DRC. And all of this has been supported by PEPFAR. So here's an example of data from the PEPFAR-supported PHIA surveys. And we're looking at the care continuum for 4 of these countries that have each conducted 2 PHIA surveys. And along the bottom, where it says PHIA 1, you can see that on the left, those are the results for the earlier survey. And then across the top, where it says PHIA 2, you can see the results for the second survey. And just to make sure we're all oriented, the lighter green color shows you the percentage of people who were diagnosed, and aware of their infection. The middle bar shows you the percent who were on treatment. And the last bar in the darkest green shows you the percent who had achieved viral load suppression. So if you run your eye along the PHIA 1 charts along the bottom, you can see that at least when it comes to that third 95, a few of the countries had achieved, like Lesotho, or were close to achieving the 95% bar. But the biggest gap in each country is the first 95, and I put a red box around it so that you can see it most easily for Uganda. This certainly had improved by the time that the second survey was repeated, but again, that first box, the awareness, remained a gap throughout in every country. So that helps us understand that awareness is a really important gap, and this has been particularly true among men and young adults, although I'm not showing you separate slides for that. This past week, South Africa released their results of their most recent population-based HIV survey. This is called the SABSUM survey. It's not done through the PHIA project, but has very similar methods, and the results really can be looked at really through the same lens. So here you can see the care continuum in 2022 for adults age 15 and older living with HIV. And let's start by looking over on your right at the total. And in the white, you can see what the 2022 results were. So nearly 90% were aware of their diagnosis. And that contrasts with 4 years earlier in 2017, when it was 85% in this darker blue color. Again, going to the middle bar, the number on ART was nearly 91% in 2022. And that's a big contrast from the 2017 results, when it was only 71%. And for those who were virally suppressed in 2022, in the white at the top, it was very close to 94% had achieved viral load suppression. That's of those who were aware of their diagnosis and who were on treatment. And that contrasts with the 2017 result of 88%. The report lays out what the prevalence of viral load suppression was among all people living with HIV, regardless of their awareness of their status or use of antiretroviral therapy. And here we can see a big improvement because it was 62% in 2017 and now has come up by nearly 20 absolute percentage points to 81% in 2022. Sorry. I'm going to now switch gears and take a look at some results from about 6 months ago that show us the state of the epidemic in the United States using data from 2021. And I'll start by reminding us all that in 2017, the United States laid out its plan for ending the HIV epidemic initiative, and that was focused on the number of new diagnoses. And using the 36,500 new diagnoses in 2017, the Ending the HIV Epidemic initiative set a target of 3,650 for the year 2030, so a 90% reduction. But what did we see in 2021? There were 36,136 new infections, so very small decline, a 12% decline in the 4 years from 2017. At this pace, the United States would have 20,000 new infections by 2030. In addition, excuse me, to the new diagnoses achievements, the report, this was from the end of May, from CDC, describes the care continuum for the 1.2 million people living with HIV in the United States, with 87% diagnosed, 66% of diagnosed persons achieving viral load suppression, with a very significant disparity in viral load suppression among those diagnosed, where individuals living with HIV who were white, 72% had achieved viral load suppression, contrasting with only 64% in Hispanic individuals living with HIV and only 62% viral load suppression among those diagnosed had achieved viral load suppression. If you multiply this out, so 0.87 times 0.66, right, the percentage of those who were diagnosed who had achieved viral load suppression, this means population viral load suppression in the United States is only 57%, and it's likely much lower in those facing structural and individual barriers. And the inverse of this, 43%, means 43% of people living with HIV in the United States are not realizing the clinical and transmission benefits of being on antiretroviral therapy. And I want to contrast the picture in the United States with the achievements in Eswatini, where there have been 3 surveys. So moving from your left to your right, you can see the results of the first SHIMS survey, very similar to a PIA survey, conducted in 2010 and 2011. Moving over to the second survey 5 years later, and then the most recent survey in 2021. And without dwelling on the specific numbers, you can see each case that the bars are going up and have nearly achieved 95, 95, 95 by 2021. That first bar, the awareness, is at 93.7. And in a viewpoint that Wafa and I and another colleague have published that's appearing in AIDS just this week, we contrast it with the situation in the United States to see how the United States really needs to think about learning some lessons from the approaches in Eswatini. Besides Eswatini and the United States, where are we globally with the decline in new infections? Here we can see that in blue, Eastern Africa and Southern Africa, as well as Western and Central Africa, have had substantial declines in new infections since between 2010 and 2022. Globally, it's a 38% decline, using 2010 as the baseline. But if you look at the bottom part of the slide, you can see there are parts of the world in red where the number of new infections is increasing. So in Latin America, it increased by 8%. In Eastern Europe and Central Asia, it increased by a very substantial 49%. And in Middle East and North Africa, it's increased by 61%. Another important gap is among key and priority populations. And here we are looking at a comparison of 4 different groups who are at higher risk for HIV acquisition because of some specific behaviors. And you can see the median HIV prevalence of these key populations in the numbers to the either to the left or to the right of each circle. So for sex workers globally, HIV prevalence is 2.5%. For gay men and other men who have sex with men, it's 7.7%. For people who inject drugs, HIV prevalence is globally 5%. And for transgender people globally, it's 10.3%. And then within each circle, you can see what the comparison is to the median prevalence of HIV, 0.7% among the general population. And this is from 2022. And I'll just point out the key and priority populations and their partners accounted for 70% of all new HIV infections in 2021. So we can begin to think about the ways in which the HIV epidemic is changing and shifting to particular parts of the population. These are not just small parts of the population. Another very important gap is in pediatric and maternal child health. 18% of pregnant or breastfeeding women living with HIV did not receive antiretroviral therapy in 2022. That's over 200,000 individuals. And only 57% of children living with HIV were receiving antiretroviral treatment in 2022. That's compared to 77% of adults. And what's quite concerning is that the gap keeps widening year by year. And children accounted for 4% of people living with HIV, but 14% of AIDS-related deaths in 2022. So clearly, this is a gap that needs attention. Here we have a chart from UNAIDS that has a lot of detail and a lot of colors, but we're going to just focus in on sort of a couple of the key parts of it. It's showing that new infections among children and the gaps in the prevention during vertical transmission. So for example, at the top in that sort of green color, it shows the mother was infected during pregnancy and the child was infected during pregnancy. The next color down is the orange, where the mother did not receive ART during pregnancy and the child was infected during pregnancy. And we can see that orange makes up a very substantial portion of the new infections. So in fact, and I've highlighted this for you here in the box, most new pediatric infections are occurring among children born to women who either never started ART, and those are the orange bars, orange sections of the bars, or in green, those who stopped ART during pregnancy or breastfeeding. So this gives us an idea of where we need to target our efforts. Another important gap is in older adults, defined as age 50 and older, who are living with HIV. And some of this is the good news of people living longer with antiretroviral therapy, but that's not the whole picture. It's gaps in awareness of HIV positive status is also quite common among older people living with HIV. That's the acronym there. And specifically looking at FIA data from 13 African countries, we and others showed that 21% of older adults were unaware of their HIV status before these surveys. And of these 21%, 54% had never had an HIV test. Another gap to point out is among mobile, migrant, and displaced populations. Mobility is a key driver of the HIV epidemic, particularly in sub-Saharan Africa, and it affects all aspects of HIV, new infections, awareness of diagnosis, and continuity of treatment. So specifically, mobile populations are more likely to acquire HIV and have new infections compared to more permanent residents across many different settings. This is often due to more frequent sexual risk behaviors and expanded sexual networks. Focusing in on awareness of diagnosis, in Namibia, migration was associated with lower viral load suppression, primarily due to lack of awareness, lack of diagnosis of HIV infection. And then thirdly, mobility also has been shown to increase the risk of treatment interruptions. So I pointed out several key gaps in the HIV response. I want to now talk about a few threats. This is not by any means a comprehensive list, but we will start by looking at the coming youth bulge. And I'm presenting here the population pyramid for Tanzania as an example, where over 60% of the population was under the age of 25 as of 2020. And that's that red box there, showing you that thickest part of the population pyramid. And with Tanzania's fertility rate of 4.4 children per woman, that means that these individuals will continue, the youth bulge will continue. So it's going to be very important to think about youth-friendly services. Easy to say, but not easy to do. Climate change is also impacting people living with HIV by causing disruptions in treatment, slowing down HIV services, and affecting the food, nutrition, and livelihood needs of people living with and affected by HIV and AIDS. These health impacts and inequalities that are exacerbated by climate change are not evenly distributed. They're unevenly distributed in society, and they have adverse effects on marginalized and disadvantaged individuals, particularly those living with HIV. Another important threat is funding. Certainly, I think many of us are aware of the current situation in Congress, where funding for the President's Emergency Plan for AIDS Relief, or PEPFAR, is getting a lot of discussion and has not yet moved through. We can see that, as this chart shows, that PEPFAR has been in a flat funding situation now for many years. There was a bump up during COVID, but really otherwise it's been a very flat picture, and that makes it a challenge to continue to address gaps in the HIV response. Another important threat is stigma and discrimination. Legal reforms are needed to achieve a supportive environment, and this means decriminalizing drug use, drug possession, sex work, and same-sex relationships, legal recognition of trans or gender diverse status, lowering the age of consent for accessing health services, and considering exceptions to standard age of consent policies. Only 23% of countries in that blue color in the circle have adopted such laws. Just over half, the yellow part of the circle, have partially adopted such laws. Here's a different view on this topic, where we're looking at the global status by country of discriminatory and punitive laws for 5 different types of laws, starting at the top with criminalization or prosecution based on general criminal laws regarding HIV transmission, non-disclosure, or exposure, moving on to criminalization of transgender work, any aspect of sex work, criminalization of same-sex relations, and criminalization of the possession of small amounts of drugs. Orange tells us that in these countries, these discriminatory and punitive laws are in existence. And just stepping back, you can see that there is a lot of orange in this chart. So globally, there are still many discriminatory and punitive laws on the books. Another point I want to bring out about the threat of stigma and discrimination, and just as a reminder, we talked about the UNAIDS 2030 target of zero discrimination, and more specifically, although I didn't show it to you, there's a UNAIDS target of less than 10% of people living with HIV in key populations experiencing stigma. And we have some data from FIA surveys in 4 countries where we asked people if they felt the need to hide their HIV status at a health facility, and 9.3% said that they felt that way. 2% reported being denied health services because of their HIV status. And we found that individuals who reported experiencing stigma were significantly less likely to initiate ART at all time points over a 5-year period. So looking at the way forward, and I know our panelists are going to be talking about this, we need to continue to emphasize treatment as prevention to reach 95, 95, 95 in all populations. And one important advance in this has been the availability of injectable antiretroviral agents so that people can have a choice between either taking pills, as we can see in the photo on the left, or having injectable antiretroviral therapy. I think there's still a long way to go to scale that up, but it is something that's going to be possible. In addition, it's going to be important to rethink HIV service delivery towards more person-centered, differentiated service delivery models. And that means adjusting the how of service delivery, including the when and the where and the what and the who of service delivery. And I think all of that will be more clear for you with this example of differentiated service delivery for mobile populations. The when is to use multi-month dispensing so that mobile individuals can have flexibility on when they want to access services. The where is to expand service delivery beyond clinic settings, to strengthen health facility network connectivity, to create multi-focus access points for ARV delivery, such as transit hubs, to use mobile brigades to help distribute antiretrovirals, and to dispense antiretrovirals at private pharmacies. So lots of different where options, more who options to use social network-based interventions rather than fixed location, clinic and community-based approaches. And the what will be new therapeutic technologies that permit mobile individuals to visit clinics less often, use longer-acting formulations, and to use HIV self-testing. There are different kinds of DSD models for different settings and different populations. Another important approach to the way forward is to adapt HIV services in response to climate change. So again, multi-month dispensing, 6-month supplies, sometimes called MMD6 during the rainy season, makes a lot of sense. Some places are using drones to supply antiretroviral agents to remote locations after climate events. And it's also important to store medical records on cloud servers so that they can be recovered after climate events. An important part of the way forward is pre-exposure prophylaxis, which again, I think our panelists are going to talk about. Right now, there are 3 types of pre-exposure prophylaxis. There's oral PrEP, which is very effective if you take it, although it may not always be so discreet, and you have to take it every day. The dapivirine vaginal ring is moderately effective, can be very discreet, but you need a new ring every month. And then CAB-LA, which is cabotegravir long-acting formulation. So it's an injection that you need to receive every 8 weeks, highly effective, very discreet, but not everybody wants to have injections. And there are implementation complexities and demonstration projects are underway. This is just to mention that CAB-LA was shown to be safe and effective through 2 studies sponsored by HPTN, 083 and 084, and ICAP was very proud to help conduct these studies with our New York sites for 083 and our Eswatini site in 084. Here's a map that just shows that long-acting cabotegravir is being approved in more and more countries. The blue shows you where it's been approved, numerous countries. Yellow shows you where it's pending approval, and red is where it's planned for submission. There's a robust HIV prevention pipeline. I've talked about some, but not all, of the currently available prevention methods that are here all the way on the left. I did not talk about medical male circumcision. I didn't talk about condoms. Here, as you move towards the center, the dapivirine ring and long-acting injectables. And then there are other agents under development, and I think I'm not going to have time to go through those. So to summarize, we've made a lot of progress with our global targets, and a lot of that has hinged on using program targets to look on a very frequent basis, certainly quarterly and often weekly, at how we're doing, using data systems, having strong partnerships, having better medications, and strengthening of capacity and systems. There are persistent gaps and threats. We've talked about some of the demographic and geographic gaps with men and young people and some countries in particular. We talked about how key populations account for a majority of new infections. We talked about the youth bulge or youth quake, as some people like to call it, the threats of climate change, the funding landscape, and stigma and discrimination. And the way forward must really accelerate prevention, and that includes treatment as prevention to reach 95, 95, 95. It includes broader access to biomedical and health delivery innovations, youth and key population-friendly services that reduce stigma, differentiated service delivery methods, and continued community partnerships. And I'll end by just reflecting and asking whether we really are at the last mile. 5.5 million people living with HIV are not aware of their diagnosis, so I'm not sure we're at the last mile. And I think it's interesting to think about what will it take to achieve the last mile. It may be much more difficult and may cost far more than the first 1,000 miles or million miles, however you want to measure it. And with that, I'd like to say thank you very much for your attention.
And thank you very much, Jessica, for your excellent presentation today. And again, I encourage all our attendees today to please do put your questions in the Q&A box. At this point, I'm going to introduce our 3 panelists today. And very briefly, they're very accomplished people, but I'll only provide a very brief synopsis of their accomplishments. And I'll start with Chris Bearer. And Chris is the director of the Duke Global Health Institute. He's a professor of medicine at Duke University. He's also an associate director of global HIV at the Duke Center for AIDS Research. He's an internationally recognized epidemiologist. He's been really working at the front lines of HIV as well as COVID-19 and much other research that he has conducted throughout his career. His work is focused on epidemiology, prevention, treatment in Southeast Asia, Sub-Saharan Africa, Eastern Europe, and Central Asia, now for more than 30 years. He's also been the past president of the International AIDS Society and has been on the advisory board of PEPFAR, and also is very active in the HIV Vaccine Trials Network and the HPTN as well. And he's also an elected member of the National Academy of Medicine. I'll move on to introduce our second panelist today, and that's Nyaratsu Ngodi. Welcome. And Nyaratsu is another accomplished researcher and has worked for many years in advancing HIV prevention amongst women and youth in her country of Zimbabwe, as well as in other areas of Sub-Saharan Africa. She's been the lead investigator in Harare, Zimbabwe, and has overseen the implementation of several pivotal studies, including oral PrEP, vaginal microbicides, the pivarin ring, and long-acting injectable CAB-LA that Jessica also mentioned, as well as also examining the role of broadly neutralizing antibodies for HIV prevention amongst women. She's also a board member of the Medical Research Council of Zimbabwe and is a deputy editor for the Journal of International AIDS Society. And last but certainly not least is Jeffrey Malimbwa. And welcome, Jeffrey. And Jeffrey is the program manager at ISHTAR and coordinates community research and technical support hub. And as a program manager, he's taken part in various activities focused on advocacy, policy, and strategy and analysis. He's also very experienced in design and delivery of evidence-based HIV and sexual health programming. And also he's a researcher as well and has been involved in a variety of different studies that have focused on key populations. I also want to mention that he's an advisory member of the Sequin Network on differentiated delivery models, and he's also an alumnus of the Human Rights Advocates Program at Columbia University here in New York. So welcome to our 3 panelists, and I think for starters, let's go around and have each of you maybe do a 3-minute or so reflection on what Jessica presented before we start the conversation and take questions from the audience. So I'll start with you, Chris.
Well, thanks very much, Wafa. And first of all, I just want to congratulate ICAP on the really impressive work over many years now in advancing these goals. And I also want to thank Jessica Justman for that presentation. And I think she did a wonderful job of laying out both the successes that we've seen and some of the ongoing challenges. I have to say that I fall somewhere more on the skeptical side of whether or not we're going to reach these 2030 targets. And that's not just because of the current funding crisis that we see with the reauthorization being stalled at PEPFAR. It's also because I think that some of the ongoing challenges are continuing stubbornly to persist. And some of those, Jessica, of course, touched on them, but I will just say first and foremost that while we've seen an increasing concentration of incident infections in key populations, we are not seeing decreases in stigma in too many places. We are not seeing governments being willing and international partners being willing to take on many of these challenges. In fact, I'm sorry to say we've been going backwards in a number of places. And we don't have to call out international partners. We could talk about our own country, but we have been increasingly limiting healthcare access for transgender populations, for example, in multiple states, and passing new discriminatory laws that specifically restrict people's access to essential care. So that's not the direction that we need to go in if we're really going to achieve these vitally important goals and finally get control of the HIV epidemic. And I think the unfortunate reality, to Jessica pointed out, of our ongoing incidents, and also the proportion of people living with HIV in our own country who are not virally suppressed, continues to be a challenge. We've worked on this together, as you know, Wafa, and it's not easy. And the last mile is very, very tough because you have the intersection of so many other aspects: social, political, economic, kind of macro level issues, but also at the level of individual people in need of services, the intersections with substance use, with mental health, with unstable housing, so many other determinants that make the folks who are still out of care particularly challenging and demanding. I think we know that. I would add that I think probably in the global South, and particularly in the PEPFAR-focused countries in sub-Saharan Africa, we continue to see insufficient ability to reach men in particular and get men tested earlier and treated earlier. And we still have, in many, many countries, if you look at where we are, a very important indicator is CD4 at diagnosis. And you see that we have not really moved it for men very far at all. And in many countries, it's still below 200 CD4. So that means that we're picking men up when they're actually starting to feel sick enough not to be able to work, provide for their families, and that is just too late to be able to prevent. I think when you look at a country like Botswana, where, it's encouraging that we've gone from a third of pregnant women to a quarter of pregnant women living with HIV, but that's still a quarter of pregnant women living with HIV. And what that means is that as they are initiating reproductive life, we have not sufficiently engaged men to really reduce that dynamic. So I think there are still challenges there. And the last thing I'll say is I saw in the Q&A a question about why Eastern Europe and Central Asia are on this very challenging, increasing trajectory, and why the MENA region is on the same trajectory. And these are multiple complex countries. It's not an easy answer, but the most straightforward answer is to say that in both of those regions, HIV remains quite concentrated in key populations, particularly among people who inject drugs. That is still the case in Russia, Ukraine, Iran, Pakistan, a number of these countries. and among sexual and gender minorities, highly stigmatized populations across these regions, and among sex workers. And so the social challenges with responding to the epidemics that these countries actually have proven to just be enormously difficult. Russia in particular, where I've done a lot of work, I think actually the numbers on global incidence would change significantly if we had real data from Russia. The Russians themselves have put out and published in Russian scientific literature, not in English, that they are documenting well under half of all new infections. They do not have a handle on their epidemic. So those UNAIDS numbers are much too low, artificially low, and hopefully someday we'll be able to reconnect with our Russian scientific colleagues and work together on that problem. Right now it's impossible. So I think that's why that region is increasing.
Thank you very much, Chris, for your thoughts and reflections. And then let's move on to Narazzo and maybe again reflections based on what you heard from Jessica's presentation, and then in brief, and then we'll move on to Jeffrey afterwards. Go ahead, Narazzo.
So thank you so much, Wafa, for the invitation, and thank you, Jessica, for let me just centralize my camera. Thank you, Jessica, for laying the groundwork. And Chris, Chris is a contemporary. We've worked together for quite a number of years. And Chris, I would like to say you're a pessimist. At this moment, I'm optimistic that we will end HIV and AIDS. I will end AIDS rather by 2030. So you thought we wouldn't get there, but I'm quite optimistic. And perhaps I just wanted to, Chris, I just wanted to make the moment a bit lighter. Let me talk a bit. And Jessica, you talked a lot about Zimbabwe a bit. And just to bring, I see we've got quite a diverse group of participants in this webinar. So just to bring the discussion to Zimbabwe. Zimbabwe is a smallish country, population maybe about 15, 16 million. And of that, we've got about 1.3 million people living with HIV, and our prevalence is 11%, just slightly over 11%. The HIV incidence is around 0.24%. And as we heard from Jessica, that Zimbabwe is one of the few African countries that have reached the UNAIDS 95 targets. Yeah, Zimbabwe, Botswana, Eswatini. So for Zimbabwe, we've reached the first 95, and 98% of our population who are HIV infected are on ART, and at the third 95, we are at 95. So our targets are on 95, 98, 95%. So really kudos to the country, and we are on track to meet the 2025 targets. And as such, I believe that the country, I'm not sure about global, so Chris, perhaps you were referring to the global, sort of the global targets. But Zimbabwe, I really think that we are on target, and we've led by example, and I'll talk about it during the discussion. As you know, we're the very first country ever to approve the dapivirine vaginal ring in 2021. Jessica talked about the ring, and we were the first African country and the third country worldwide to approve injectable pre-exposure prophylaxis. So I think we are on the right we are in the right direction to end AIDS by 2030. And we can see in Zimbabwe the new infections are declining, and the HIV incidence in 2022 had fallen from 0.2 that I talked about to 0.17. Even if I say that we need more targeted efforts in terms of if we are going to continue on this positive trajectory. As a country, really, I think we need to have more targeted efforts, including equitable service provision and targeted demand creation initiatives so that we prevent the new HIV infections, especially among key populations and vulnerable populations. So let me perhaps just bring you back to the 95, 95, 95 targets. I said in Zim we're at 95, 98, 95%. That's for the general population. But when we come to the key populations, Jessica talked about the fears, so I'll refer a bit to ZIMFIA. So we compared 2020 ZIMFIA, the Zimbabwe fear data, and that was in the general population, and it was compared to data from the key populations. The key populations, this was a biobehavioral survey. So ZIMFIA included individuals who were 15 years and older, but the Zimbabwe Biobehavioral Survey included individuals 18 years and older. This was a cross-sectional survey using respondent-driven sampling, and it looked at HIV testing and viral load in key populations in men who have sex with men and other gender minorities. What the BBS showed is that even though 95% of the general population in Zimbabwe, we've achieved all the 95% targets in the general population, less than 50% of key populations in Zimbabwe know their HIV status. So that's really a gap we as a country need to reduce so that we can reach 2025 targets and 2030 targets. Our key populations, only 45% have reached the first 95, and of that, 93% are on treatment and 81% are virally suppressed. But the cumulative viral load suppression in the key populations is very low, as shown by the BBS. So we really need, that's one of the gaps that we as a country need to target so that we reach a national 95, 95, 95, including all the key populations. And Jessica, I think you also talked about pregnancy. So I'll just also come back to Zimbabwe. If you look at most sub-Saharan African countries, and we know if you juxtapose the map where there's high HIV rates, you'll see that those are the very same countries where we have high fertility rates. So if you look at sub-Saharan African countries, women like me, we spend on average, women in Zimbabwe, we spend 7 years of our lifetime breastfeeding or pregnant, compared to 9 years in Malawi, 10 years in Uganda, and 4 years in South Africa. So that's quite a significant time in our lives. So we need to ensure that women, young women and their partners do not get new HIV infections, so that we eliminate mother-to-child transmission. So I'll also, with time, I'll talk about pregnancy and how women in Zimbabwe and sub-Saharan Africa continue to be at risk for HIV, and as such, HIV might still be passed. There will still be vertical transmission to infants. So I'll talk a bit about pregnancy, time given. So I think those were the two gaps that I wanted to bring to your attention. The key populations, we need to do more, and then young women, especially young women and their populations. So, but at the end of the day, I'm optimistic that we'll get there as a country. So thank you. Back to you, Wafa.
Well, thank you very much, Nerato. Very much appreciate your inputs. And let's move on to Jeffrey, please, and your reflections on the presentation. Thank you.
Thank you very much. And to me, it's more of a celebration, just to say that it is exciting to see that key populations and recipients of care are part and are also on the table to discuss some of the issues that they might need to be addressed. And some of these achievements include visibility of the work we do and the innovations that we've been able to deliver to ensure that we reduce the effects of HIV amongst our community, including the peer-to-peer models. It is also important for us to recognize that despite all this, there are certain challenges, of course, that have been highlighted in the presentation, including stigma, discrimination, criminalizing laws that have continued. And you can see that in the recent past with some of the countries passing laws against key populations, and that inhibits their and so does not allow them to access services within those facilities. We've had pandemics that have come up like COVID, and these have also created and helped us understood some of the structural barriers that we still need to address if we want to end AIDS by 2030. But also highlighted 4 key points that we need to look at. One is human rights advocacy, and this is trying to remove the legal barriers that kind of perpetuate stigma and discrimination. We need to emphasize on community engagement and trying to see how best can we allow communities to participate in designing and implementation of HIV programs. And then also the issues around funding, because yes, there's a reduction of funding for some of the key populations programs, and that kind of reduces the efforts that are made by communities, and also innovation. And this can be looked at maybe through looking at technologies and prevention methods, including injectable PrEP and outreach strategies that adapt to the evolving challenges like COVID-19 and the political homophobia. Thanks.
Thank you very much, Jeffrey. And we'll get back to you, I'm sure, with some of the issues that will come up. I'm going to go back to you, Chris. And, you know, as you noted, you must have noted from Jessica's presentation, is that in the US, we still have substantial gaps and we lag behind. And probably we have a lot of the challenges that everybody's been talking about are reflected in the US epidemic now. And I know that you've been a firm believer in trying to find ways to be able to identify new ways of prevention of HIV in this country, in the US, and the research, your leadership over the research in the HPT. And I'm wondering if you can talk a bit about the philosophy behind the research and the approach, the idea of going beyond the biomedical and combining other interventions to tackle this challenge.
Yeah, thank you, Wafa. Well, I think what we've seen is, of course, over the last decade and a half, really 15 years, maybe more, since really 2011 with the first daily oral PrEP trials with Truvada, that we've entered an era where we really have just a number of new prevention tools, mostly biomedical prevention tools. And they have really started to have powerful impacts on epidemics where people have access and where they're used. So, for example, Australia is getting very close to eliminating HIV transmission. Their epidemic was very concentrated in gay and bisexual men, kind of overwhelmingly, and the uptake of oral PrEP and also on-demand PrEP, which is used there, is really reaching very high levels, and we are seeing genuine declines in incidence to very low levels. With high uptake and use of PrEP. When you look at our country in the United States, what you see is that that has worked very well for majority gay and bisexual men and other MSM. So white MSM, we have more than 90% of white MSM in this country who have an indication for PrEP are on PrEP. And we've had really impressive declines in new infections. So we know this can work. We know that it can work for individuals to protect themselves, and it can also work at population levels to reduce incidence in these communities. What is not happening is the same levels of declines in new infections and the same levels of uptake and use of these new technologies in minority, Black and Latinx men who have sex with men, and transgender women who have sex with men. Now, these communities, MSM in general, but particularly minority communities, now account for the majority of new infections in the US. So this is our challenge. This is the population. And what we see is that a technological fix is not delivering for these populations in the same way. And if you ask yourself why that is, you immediately encounter the social determinants of health. There are still 10 states, mostly in the Deep South, that have not expanded Medicaid through the Affordable Care Act. So Americans will understand that. For the wider audience, what that means is there's still populations where there are people who are uninsured or underinsured. And in our system, if you don't have health insurance or you have very limited, only catastrophic health coverage, it's really a challenge to get these services. We have, of course, stigma and discrimination that we have to take on. We have to take on equity as a challenge, and we have to take on stigma and discrimination. So the approach we've taken in the current HPTN trial that has been under development for several years now is to have a combined intervention aimed at the social determinants of health, specifically for Black African-American MSM in the South, in those states where these challenges really persist. We're doing this now in 5 US states. The intervention includes taking on intersectional stigma. And intersectional stigma is the kinds of overlapping and interrelated challenges that communities face. It was developed to think about health and social justice issues for African-American women who face sort of the dual stigma of sexism and anti-Black racism. For Black gay men in the South, there are multiple layers. So there is, of course, anti-Black racism, there's homophobia, and there is also the stigma that's associated with HIV, which persists, or which being at risk for HIV, which is a real barrier to PrEP. So we're taking that on as an intervention target. We have developed an intersectional stigma reduction program for healthcare facilities, for everybody working in healthcare facilities. And that is one of the components of this intervention. There's also a social media component, a health equity component, and a peer-to-peer component. And I noticed, Jeffrey, that you mentioned the peer-to-peer elements and how important they are. That is true, I think, for sexual and gender minority people all over the world. That we need to be communicating with our peers on these issues. And so that's the combination approach. And I have to say, it's one of the HPTN integrated strategies. We're trying to integrate strategies from a number of disciplines. I think that this is really critical work because, you know, we really have now a powerful, diverse toolkit to take on this epidemic. And our challenges are so much in implementation. I would say, you know, if you look at the African context, the numbers that Jessica presented on children and how challenging it still is to get kids living with HIV on antiviral therapy, that's the same kind of thing. We really have to take on the barriers. We have treatment that's effective. We can get these kids to live very long, healthy lives, but we're not reaching them. And that's a related, different challenge, but I think it's related to some of the same social structural empowerment issues.
Thank you, Chris. And so true. I think we said it again and again, there really is no magic bullet. It's we have to really be thinking about the context and for the individual and the societal context as we shape our services and interventions. Moving back to you, Narat, so I know that, and you're well aware that women in sub-Saharan Africa and Zimbabwe, I'm sure, they kind of not only bear the brunt of HIV, but they also there are also issues around access to unmet needs for contraception, as well as other STIs, non-HIV, sexually transmitted infections. And how are you in Zimbabwe? How are you thinking about tackling, addressing this triple burden that these women face?
Sure. Thank you. Thank you, Wafa, for that question. So perhaps before I go to that point of discussion, I would like to just maybe call out to Pamela Morrison. She had asked about if Zimbabwe is managing to promote exclusive breastfeeding. So yes, and we have made great strides in terms in all our clinics, in all our primary health care clinics, the process is such that when women are coming to a well baby clinic, for example, everyone must present early. And when they do present, there's a health education. It's like a group in education. So women get a lot of education, both those who are on ART, those who are not on ART, but we do talk about exclusive breastfeeding, the pathology of infant gut development, and how and why mixed feeding before 6 months will predispose infants to HIV and other gut infections. So women, African women, Zimbabwean women, they are very protective of the pregnancy as well as infants. So they do a lot. They go an extra mile to promote, to protect their infants. So usually the health education works. So it has really helped to promote optimal infant feeding practices. So we've done a lot. So thank you, and thank you for the congratulations in terms of the progress we've made as a country. But back to you, Wafa. You talked about, yes, women here in Sub-Saharan Africa and Zimbabwe, we continue to face this triple burden of HIV, STIs, and unmet need for contraception. So if you look at the results of ECHO, for example, you see that many women who had unmet need for HIV, for pregnancy prevention, the risk of HIV is higher. We know that STIs predispose us, everyone rather, to HIV. So what, in my opinion, as we talk about the choice agenda, as we talk about more options, I would like to really bring to your attention that we should, and let me hasten to say, in Zimbabwe, and I'm sure the rest of Sub-Saharan Africa, women are more concerned about pregnancy prevention, and it is less stigmatizing. So we want to capitalize on the successes of pregnancy prevention, which is less stigmatizing and which is more acceptable, has been successful. So this brings me to the discussion on multi-purpose prevention technologies. We African women, we really are the ones who are looking after the families, going into the fields, looking after sick relatives. So there isn't time to think about PrEP, to think about HIV prevention, to think about pregnancy prevention, to think about STIs. So we really need something which is multi-purpose. So, and there are many multi-purpose prevention technologies which are being researched on, all the way from preclinical studies to clinical. So I just wanted to bring that to many people's attention, that multi-purpose prevention technologies. And when in qualitative studies, when African women were asked, what type of product would you like, including Zimbabweans, Kenyans, South Africans, they said that they want either a 2-in-1 product or a 3-in-1. So we really need to have those multi-purpose prevention technologies. Yeah, thanks.
Thank you. And I think that this highlights the importance. I mean, we've talked about the importance of implementation and taking our discoveries to action to make an impact. But I do think, as you mentioned, highlighted, we also need to continue that pipeline of innovation as well, to identify new tools and so on, and multi-purpose tools as we move forward. Moving on to you, Jeffrey, I was thinking about the one of the issues that we're facing is the current situation with regards to structural violence, particularly faced by key populations. And what are some of the approaches that you can help in mitigating and can help in mitigate some of this, some of these structural hindrances, and enable access to HIV and sexual and reproductive health services for key populations?
I think the first thing that would help is having data, and data that is going to be able to tell the story, the gaps that are there in access to health for key populations. One of the critical strategies that we also need to look at is the role of community mobilization, the peer-to-peer models that need to continue because that helps mitigate access to service, distribution of commodities within the community. there's also the one thing that we also need to look at is coming up with models like the differentiated care model. We did a study, and one of the outcomes of that study was communities saying they want different ways to be able to access some of these services. And we did it through the hotspots. We've done it through the community drop-in centers. We've done it through use of technology, social media. But we need to continue creating some of these models to ensure that there's no gaps in service uptake for communities. Advocacy is very important. And just to respond to one of the questions in the text is, what is it that communities can be able to do together with healthcare providers? One is creating awareness, creating key population-friendly services. And this brings me to one thing that we need to say and have person-centered approaches. And this is how we define person-centered approach. It entails provision of individualized care that is holistic, engaging, responsive, respectful, with key populations in defining their care in consultation with policymakers and service providers. That will be quite critical for us to address some of the structural barriers that we continue to face. Thank you.
Thank you, Jeffrey. And thank you for addressing that question that we received. And going back to you, Chris, you know, in a commentary piece that Ambassador Nkangasang put in the journal Nature, he does highlight the issue of potentially using a social network approach to conceptualizing, you know, in trying to reach specific populations as well as also how to engage them and so on. And I know that you've done work on social networks and so on, and maybe you can give the audience a bit of a sense of how you see that utilizing social networks can help advance our ambitions here.
Well, I think, you know, in Jessica's talk, she underscored that one of the gaps is really young people, right? Mm-hmm. And of course, we're dealing globally, as we know, with the largest cohort of adolescents in human history. So not only are they a very large community, they're also connected and linked in ways that previous cohorts of young people were not. So the challenge is, you know, that many of the approaches and the ways that we have reached people in the past, and traditional clinic-based approaches and community outreach, don't necessarily get to these folks and don't get into the information networks where they are accessing information, where they are looking for services. So my first experience of this was a project we were doing on PrEP implementation in Bangkok and Pattaya, Thailand, with young male and trans sex workers, 18 to 26-year-olds, a very, very high risk group who we thought would really benefit from PrEP, and the PrEP uptake among this group was really quite low. And eventually we started working with some of both the network groups, APCOM, the Asia Pacific Community of MSM organizations, and then also with some of the media groups. And they essentially, they did some outreach and focus groups work for us and really came back and said, nobody wants to read anything. You're going to have to do short informational videos. That's how people are accessing information and content. And you have to get this out on the social media channels that people are actually accessing. And remarkably enough, for a relatively modest investment, we were able to reach 5 million LGBTQ users in Thailand. Now, not all of them are young and not all of them are sex workers, but that's very high penetration. And we did this in pulses, and we were able to show really that our enrollment and engagement and uptake doubled every time we put this information out. And it was the first time that I really understood the power of social networks to really reach the people that were not being reached. So that's going to be a big part of the HPTN trial that I spoke to earlier, HPTN 096, using social media, using the platforms, using social networks to reach folks. And I think the best evidence we have of how powerful this can be was last year's outbreak of Mpox. So the Mpox outbreak, spread very quickly in networks of MSM, gay and bisexual men in Europe, and then, of course, very quickly in the United States. And we had a rapid number of new infections. New York City, where you are, was one of the most affected cities. And the word went out through the gay community with incredible speed that this was happening. People were, very motivated and mobilized, and the CDC was able to look through basically using social media analysis at the changes in behavior, and it was just dramatic. People significantly reduced their number of sex partners. They significantly reduced the number of anonymous partners. There was a very rapid uptake of vaccines, the Jynneos vaccine. There was less vaccine hesitancy in the LGBTQ populations than there are in other majority populations. And that outbreak in the United States came under very rapid control. And I think that what that shows you is that if we can harness the power in those kinds of social networks, we can have a really big impact. It's about partnership and engagement, and using the tools and platforms that the communities have developed and are using. That we need to be there. They need to be accessed with high quality scientific content.
Yeah, that's an excellent example, actually, and a very recent one, and it also demonstrates the value of the importance of trust and building trust and so on. And that obviously is something that takes it doesn't happen overnight, but it's something that all of us have learned requires this ongoing engagement and demonstration that the work is trustworthy in many ways. So I have to say that Zimbabwe has always been at the front of the line in embracing innovations, and maybe part and parcel of partly this is due to your such a intensive engagement and willingness to engage in doing the research, the initial research, and so on. Can you share with the audience where we're at in terms of Zimbabwe and the whole issue of access to two new modalities for PrEP, the dapivirine ring and also the long-acting cabotegravir for prevention?
Thank you, Wafa. And I think the successes of Zimbabwe, we owe it to partners like you, Wafa, and everyone else whom we work with. So it's not as solo successes. But yes, we do a lot of community engagement. We work, and I like you said in the beginning, I like the theme for World AIDS Day that community-led is all about community. So we've done a lot in terms of community engagement. And as I said before, when I started with my presentation, Zimbabwe, we were among the first to register the dapivirine ring and long-acting CAB. And I owe that. I think that success we owe it to the regulatory bodies, the Medicines Control Authority of Zimbabwe, really, right from when we started HPTN 084 and the MTN 020 or 025, where we looked at the dapivirine ring. They were really there monitoring us, coming to do site inspections, so they knew about these products way before they were proven safe and efficacious. So as a result, the regulatory pathway was really streamlined, and we were happy that the country registered these two products, which add on additional options to the HIV prevention toolkit. That having been said, we are still planning for implementation research. So Zimbabwe is part of the Catalyst. We will be conducting the Catalyst study, where we have 6 sites across the whole country, which will be offering oral pre-exposure prophylaxis, as well as the dapivirine vaginal ring and CAB-LA. And I'm sure we'll be starting sometime in 2024, early 2024. So I'm happy that we are including these two options, but it won't be without challenges. We need to continue educating our healthcare providers in terms of how best to administer these two products. We know that there's always provider bias. If I, as a healthcare provider, if I don't know about an intervention, I'm not going to talk about it to my patient, to my client. So we still need to do a lot of community sensitization, a lot of healthcare provider training. Thank you.
Thank you. I know we have only a few minutes left, and I thought kind of at the end I would throw out one question to each of you and quickly go through, and you can provide your responses. And you know, when you on World AIDS Day today, which is you know, always is a bittersweet moment, because I think it's kind of we always recall all the losses, all the people we've lost, all the tragedies, but I think it's also a moment of really acknowledging, like we've all done today, the progress that's been made. And it's also a moment where we energize ourselves and to face what comes ahead. So I'm just wondering, and for each of you, if you can think of one thing that you feel is the one most important thing that you feel should be a priority for the global community moving forward. And I'll quickly go around the room here and start with Jeffrey. There's one thing that you feel is the most critical thing for us to keep in mind.
I think for me, the most important thing is to ensure there's community engagement and community participation in the fight, and just ensuring that the voices of community are recognized in all the efforts. Thanks.
Thank you. Nothing, truly nothing about us without us. Thank you. Chris, what about you?
Well, I think we all have experienced, certainly our generation, Niradzo, Wafa, we've lived through the period where there was no effective therapy, and the sea change, the world that we live in now, where there is effective therapy and people are really living healthy, full lives, productive lives. We still have that gap of 10 million people worldwide, at least, living with HIV who are not on therapy. And that we have to close. We really have to do that. We can do it. PEPFAR has shown us that we can do it, but really everybody living with this virus should have access to antivirals. And what a glorious day that will be. Thank you.
Niradzo, what about for you?
Sure. So I'm going to somehow echo the two previous speakers, community, as well as ensuring that everyone who needs some form of intervention, whether it's prevention or treatment, that they get it. I would like to bring in that the priority for the community really, at the end of the day, what we do must be human-centered. You know, if we're just thinking about numbers, figures, and don't care about the person on the ground, then I think we might miss the boat somewhere. Let's think about the person at the end of this discussion. You're thinking about an African woman, and you're looking at an African woman like me, you should think that we want to make sure that Niradzo doesn't get HIV, STIs, unplanned pregnancy. So let's give this. We used to say HIV and AIDS, they've got a female face in Africa. That's not the human-centeredness I'm talking about. Let's care for people. Let's care for community. Let's give the people the interventions that they need. And I'm summing up all of our three thoughts. Thank you.
Well, thank you very much. Truly, let us not leave anyone behind. I want to end by thanking Jessica Justman. I want to thank you, Chris, and I want to thank you, Niradzo and Jeffrey. Thank you all for joining us today in this moment as we acknowledge World AIDS Day and make a commitment to always be thinking of communities in the lead. Thank you and have a good day, everyone. Take care.
Thank you all.
Thank you.
Thank you.
Bye-bye.
Yes.